This video is aimed at healthcare professionals who have some understanding of FES. The video will show electrode placements that can be used to correct drop foot and how to adapt these placements to achieve the desired movement at the foot and ankle. To correct drop foot, we want to stimulate the common peroneal nerve. This passes behind the head of fibula and then divides into deep and superficial branches. The superficial branch supplies the peroneal muscles, which produce ankle eversion. The deep branch supplies tibialis anterior, which produces dorsiflexion with inversion. To locate the head of fibula, start with the leg in a slightly flexed position. If the knee is flexed to 90 degrees, the head of fibula will be more difficult to palpate. Start at the lateral malleolus and slide the thumb up the centre of the leg. The first bony lump that you feel will be the head of fibula. Starting at the ankle and working up means that you will avoid the tibial condyle, which is located anteriorly. To find the standard electrode placement, place an electrode with the top front corner of the electrode over the head of fibula. When palpated, this corner will feel hard over the head of fibula, whereas the other three corners will be softer. Before placing an electrode, you can wipe the skin with water if it needs cleaning or if the skin is excessively dry. Using a small amount of water will improve the conductivity of the electrodes. The second electrode is placed over the motor point of tibialis anterior. Ensure that you avoid the shin bone when placing this electrode and position it over the fleshiest part of the muscle. Connect the black pin to the top electrode and the red pin to the lower electrode. Turn the ODFS pace on and enter the clinician menu using the 3-button trick. Select New Setup, Dropped Foot and Heel Rise, as we want to stimulate when the foot is lifted from the floor. Select Output Current and position the patient so their foot is supported up from the floor and free to move. This will enable you to see the response from FES more accurately. Turn the intensity of stimulation up by pressing the test button and increasing the current until you gain the desired response. This is normally eversion with dorsiflexion. If you are getting too much eversion from the standard position, you can adjust the position of the electrodes to correct this. One way of doing this is to press test and gently drag the electrode forward or back when stimulation is happening. Be sure not to press down on the electrode, as this will increase the intensity of stimulation. Sliding the electrode anteriorly will normally produce more inversion, and sliding the electrode posteriorly will produce more eversion. Once you have found a more optimal position, you can peel the electrode off and resite it. This can also be done for the lower electrode. It is good practice to only move one electrode at a time and test the response before making further changes, rather than moving both together. It is not recommended to spend a large amount of time perfecting the electrode placement in sitting, as the movement achieved in sitting is often different to walking, where muscle length and tone are different. It is normally beneficial to have some eversion in sitting, as in walking this enables a more stable ankle at heel strike. The standard position has the black pin connected to the electrode over the head of fibula and the red pin connected over the motor point of tibialis anterior. The default setting on the ODFS pace is an asymmetric biphasic waveform. This means there is a stronger effect from stimulation under the black pin. In this case, it means eversion is biased over dorsiflexion. This effect can be useful clinically as we can bias different movements. For example, if we wanted to reduce the amount of eversion, we could swap the polarity of the electrodes and connect the black pin to the lower electrode and the red pin to the top electrode. This will now bias dorsiflexion and should reduce the amount of eversion seen. Although this effect is sometimes beneficial, we do not use it a lot in clinical practice, as we normally find that adjusting the electrode position and waveform is sufficient to get a good balance between inversion and eversion. The ODFS PACE has two options for waveform. An asymmetric biphasic waveform is the default setting. As already discussed, this creates a stronger stimulation effect under the black pin and can be used to bias different movements. The other waveform option is symmetric biphasic. This means the stimulation effect is equal under both electrodes. For many people, this will produce an effective balance between inversion and eversion, and for some people it is more comfortable than an asymmetric waveform. The symmetric waveform is also less likely to cause skin irritation and should be used for people with a history of skin irritation or those with more fragile skin. To adjust the waveform, enter the clinician menu, select fine-tune settings, and then rotate the dial until you get to output waveform. You can then swap between symmetric or asymmetric as required. For patients who have issues with toe clawing when walking, this electrode placement can be beneficial. It can be used in combination with a domed insole in the shoe. The lower electrode is moved distally to stimulate the motor points of extensor hallucis longus or extensor digitorum longus. This will have the effect of stimulating greater toe extension with dorsiflexion, which can be useful for patients prone to toe clawing. The waveform and polarity could also be adjusted for this electrode position, as well as moving the electrodes medially or laterally to vary the amount of eversion or inversion. The popliteal fossa electrode placement can be used to improve hip and knee flexion in swing phase. One electrode is moved over the popliteal fossa at the back of the knee. The biceps femoris tendon of the hamstrings can be palpated, and this should be positioned to run through the centre of the electrode. The lower border of the electrode should be level with the crease of the knee. If you place the electrode too medially in the popliteal fossa, you may stimulate the tibial nerve, which will produce plantar flexion. If you are too lateral, you may get stimulation of quadriceps, so monitor carefully the response achieved with stimulation. This position stimulates the withdrawal reflex, which produces hip and knee flexion, ankle dorsiflexion and eversion, as well as some hip external rotation. This can be useful for patients who lack hip and knee flexion and clearance of the limb in swing phase. This electrode placement is often more sensitive, so reduce the intensity of stimulation before testing. The waveform and polarity can also be adjusted with this position to bias the response achieved. It is also possible to place the lower electrode over the motor point of tibialis anterior rather than the head of fibula if less eversion and more dorsiflexion is required at the ankle. If too much eversion is achieved with the other electrode placements, both electrodes can be placed over tibialis anterior. This will bias dorsiflexion with less eversion. Palpate the shin bone and avoid placing the electrode directly over this. Place one electrode over the motor point of tibialis anterior and the other more distally. This electrode position is a good starting point for paediatrics or younger adults who tend to be more sensitive to eversion. As this is stimulating the deep branch of the common perineal nerve, a higher intensity of stimulation is often required. It is recommended that all patients are issued with photographs to support them in placing electrodes and replicating the setup at home. Use bony landmarks and any freckles, tattoos or scars to aid the patient in locating electrodes. In this example, the head of fibula is in the top front corner of the top electrode. The edge of the top electrode lines up with the edge of the lower electrode, and the gap is 2 of the patient's finger widths. The shin bone is medial to the lower electrode. In this case, there are also freckles that can be used to aid placement. Printing and laminating the photo means that patients can keep it with their electrodes and stimulator and easily refer back to it when placing electrodes. It is also possible to draw around the electrodes with permanent marker. This will last for a couple of days and give patients some time to learn the anatomy of their leg. It is not recommended to use pen markings as a long-term guide, as when the markings are redrawn, they often drift slightly, which will affect the stimulation response achieved. If pen markings are required, it is good practice to use red and black to correlate with the colour of the pins. This is particularly important for an asymmetric waveform. This video has shown the most common electrode positions to correct drop foot. Not every position will work with every patient, so an awareness of alternative electrode positions is useful. It is also worth considering adjusting the timings and other stimulation parameters to get the optimum drop foot correction.